So welcome, good afternoon everybody. We are here with Dr. Karen Pardee, who's going to present some information about a social prescribing transformation project in her cluster in southwest Cardiff. Many of you will have been on the call we had at lunchtime on Tuesday, where Karen had the opportunity to present her project with other panelists when we were looking at value and health in primary care. So today Karen has half an hour to do a presentation, and we'll learn a lot more about this project, which has created so much interest. Just to tell you a little bit about how the session will run, Karen has her presentation of slides. There's some data at the end, which she's asked me to orientate you around. My role in this project is really in support of the cluster team, helping to evaluate their interventions and the value for patients and impact on patients as the clinical improvement lead, and that's why I'll be helping around the slides at the end. But we're going to hand straight over to Karen because she's got lots to tell us. She's got a presentation. We have the opportunity for you to ask questions, so please put them in the chat. We'll endeavour to answer them either at the end of the session, or if not, we'll make sure we get back to you on email. So please get involved and ask your questions. And Karen, I'm delighted to introduce you to those who haven't met you. Dr. Karen Pardee, cluster lead and GP partner for the Southwest Cluster and Lansdowne Surgery.
Thank you very much, and thank you, Sue, and thank you so much for the opportunity to come and talk about the work that we're doing in Cardiff Southwest Cluster here today. It's a really exciting opportunity. Just to tell you a little bit about clusters for those who might not be familiar with them, these have been set up in Wales now for a number of years, and they are primary care clusters based on geographical areas which are aligned to the local authority areas, and they encompass the GP practices within those areas. And in Cardiff Southwest we now have 10 of those practices. But it's not all about GP practices. It's about primary care, which involves the other community healthcare providers within the area, but also local authority, social care, and very much community and the third sector voluntary organisations within those areas. And in Cardiff Southwest, we've built really strong relationships with our community partners, and particularly our third sector partners, which were really the basis for social prescribing in our area and the project that I'm going to describe today. Could I have the next slide, please? So around 2 years ago, we were fortunate to be part of a Cardiff and Vale Health Board bid for the Welsh Government Transformation Fund, and we formed part of that bid as an accelerated cluster. And in putting this bid together, we drew inspiration from the Compassionate Communities work that was started in Frome in Somerset. And this has been really inspiring work in that the GP practices started working very closely with their community, and they found dramatic results in terms of healthcare within that area. Particularly, they saw a dramatic reduction in hospital admissions, emergency hospital admissions, which is a really exciting development. So we looked at that project and we drew inspiration from it, but very much wanted to develop it to a Cardiff Southwest Cluster approach. Next slide, please. So we formed our Accelerated Cluster Transformation Project, which has 4 main elements. And the key to this is, as you see, we've got our patient here epitomised by Win, but our patients are very much at the heart of everything we do. We're very much around patient-centred care and looking at the best way to support our patients, which we recognise is not just through healthcare, it's through that holistic approach. So the 4 main elements we have to our project. Firstly, I've mentioned already community support. So we've had great connections with third sector providers within our community, and we've developed social prescribing now for a number of years, and we really wanted to embed that and enhance that within our local area. So we commissioned a third sector organisation to run our community development service, which comprises healthcare connectors, so wellbeing coordinators, social prescribers. They go by many different titles, but really about link workers who are linking people to assets within the community that can help to support them. And this might involve many, many things. It involves things that promote health, such as healthy eating, exercise, but also around social needs, such as debt and housing. But very much we're looking at social isolation and how we support people within their community, because obviously social isolation has such a big impact on people's well-being. Our community development service not only does the link worker role, but very much looks at what's available in the community and looks for gaps. And through them we've identified some key gaps that patients have told us about. Things, for example, walking groups for women in certain areas of our population was felt as a need, and so that's been addressed and has been set up by the community. And so this is very much the ethos that we are hoping to promote through this work. The next stage that we went to was our multidisciplinary team meetings. And this is very much around making sure that we are providing holistic care for patients, often with quite complex needs. And so we set up MDT meetings, and we just basically invited lots of people along, really, just to start off with. And we invited people, as I said, healthcare providers, so district nurses, people from mental health. We also looked at social care, our independent living service attend the meetings, and also our third sector. So we have a couple of key third sector organisations that we work with, and we invited them along as well. And it's been really great to get all those people in the room. I'll talk a little bit more about that in a minute, about how we help to support people. Again, looking to Froome and the model they set up, they had a discharge liaison hub that they set up. And this is around supporting people when they first are discharged from hospital. Obviously looking at trying to prevent avoidable hospital admissions. People who've just come out of hospital are often at high risk of going back into hospital. So we're looking at how we can best support people, keeping them at home, providing care at home wherever possible. And so we set that up in our cluster, but we've kind of gone one step further. We set it up initially just looking at a patient's discharge from hospital, but particularly during COVID, it became very evident that there was a much greater need, not just people who come out of hospital, but people preventing them from going in, a lot of fear about going into hospital, people very much wanting to be cared for at home. So it's really evolved into an integrated care hub. And again, I'll describe that a little bit more in one of the coming slides. Care planning is a key part of the Compassionate Communities model, particularly advanced care planning, looking to support people in making those decisions towards the end of life, but making them in a timely way. So it's not a panicked conversation just in those final days or hours, but really helping people to make those decisions in advance about where they'd want to be cared for, and supporting them and making sure the appropriate support is in place so that they're able to have their wishes fulfilled. So that's the four main elements of our project. I'll now go on to describe a little bit more detail around them and then come on to some of the evaluation. So can we have the next slide, please? So this is our MDT meeting, a typical one as it started. As you can see, lots of people in the room, and it was just great for getting to know what people did. And I think this was certainly in the early meetings, the conversations were very much around, I didn't know you did that. and also, you know, looking to find out where that best support is. There's a lot of overlap between different services, and often, you know, people have quite complex needs, and it's good to have those conversations to think, all right, you know, where's the best fit? Again, you know, very much person-centered. What's the best fit for this person? Obviously, this picture was taken pre-COVID. We no longer have our meetings in the room like this. It was great to get to know each other, and I think it was important having that face-to-face element to start off with, because we've built really strong relationships. But now, well, very quickly, obviously March came and COVID, and we moved to virtual meetings, which we have now. They're held every week across the cluster, and they work really well in that virtual environment. Obviously, we're all getting very used to it now, and also having those really strong relationships at the start were very helpful and beneficial to our MDT meetings. Can I have the next slide, please? As I said, our integrated care hub evolved from that discharge liaison hub, and we have in our hub, we have occupational therapists from the community resource team. We have our cluster pharmacists who, again, during COVID, what a fantastic support they provided for patients. A lot of anxiety about people being able to get medication, get prescriptions, and they liaised with the community pharmacies and with our third sector voluntary organisations to help people to get their prescriptions, their medication. We have our third sector organisations as well. Our Wellbeing connectors are based within the hub, and they're key to as that link between those sort of statutory services and the support that's available in the community. During COVID, our Wellbeing connectors made weekly phone calls to some of our more vulnerable, isolated patients, and that was, so supportive for those people during a really anxious time for them. And inevitably, we will be continuing to do that as the COVID situation escalates at the moment, and it's a really great resource for our patients. I'll just put up some of the feedback we've had from patients here. Great feedback both from patients and also from staff, from GPs, practice staff. We very much encourage, this is not just something for GPs. Anyone can refer into the hub. We have receptionists, practice managers, we have wellbeing connectors, people from the community resource team and other healthcare providers. Anyone can refer into the hub and just someone, I'm just worried about this person, and it can save so much time of sort of phoning around trying to find the right support for people. Whereas come into the hub, we've got access to all of these resources, all of these different expertise within the hub, and it's a really valuable resource. Can we have the next slide, please? So our community wellbeing service, I've talked about them already. It's quite obvious, I'm sure, that I just think they're fantastic. I'm bowled over by the warmth and the energy and enthusiasm within the community to really support people who are within that community. And this is just gives some examples of some of the activities that they've arranged. Again, obviously things have changed very much during COVID, but really adaptable organisations who very quickly moved to do things in a different way, supporting people remotely. For example, we have a Grow Well, a garden project, which obviously during COVID we couldn't hold our face-to-face sessions, but they were contacting the volunteers at home, delivering seed packages and supporting people to do their own mini sort of garden projects at home, but still having that vital support for people, particularly who are isolated. Our wellbeing service and our wellbeing approach in the cluster is not just about our patients or members of our community. It's also all about the people who work with the people in that community, and our vision for the cluster is health and wellbeing for all who live and work within that community. And so we're very much about looking after us, the people who work with the community, because we appreciate that it's really important that we look after ourselves so that we can look after others. Could I have the next slide, please? So this is a bit of data looking at the advanced care planning, which I described previously. We've done training to promote staff to be able to have that conversation about advanced care planning. And again, this is not just GPs, this is not just a realm of healthcare professionals. Anybody can have a conversation with somebody about what their wishes are towards the end of life. And so we've got some initial data here comparing advanced care plans that were recorded in 2019 compared to 2020, the same time period in 2020. And we've seen a a big increase in the recording of advanced care planning and also other things around that, such as coding for resuscitation and anticipatory medicines prescriptions. So a lot of this is inevitably because of COVID, and it was necessary for us to maybe be having a lot more of these conversations with people, particularly in those initial stages of COVID. But also it's around the recording. So one of our GPs in our cluster, Rachel Lee, has led on developing a guideline within our GP IT systems, which facilitates the recording of this data. And that's so important. It's important that if somebody has expressed wishes, that that's then disseminated to all the people who might need to know that. And so having a good system of recording that information is really important. Can we have the next slide, please? So evaluating what we're doing, it's a huge project with far-reaching potential. We feel this is a great thing. We've anecdotally, we see the impact on our patients, we see the impact on our staff, the enthusiasm of people who come along to the MDT and how they really value being able to support patients so much more effectively and form those really good relationships with other professionals. But obviously we need to evaluate things more formally, and it has been quite a challenge. But we are now, bringing together data to support that evaluation. Obviously, great to have the help of Sue and her team in this. And so just I'm going to hand over to Sue now just to talk a little bit and orientate us around some of the slides showing some of the data now. Thank you, Sue.
Thank you, Karen, for that, and also for the opportunity to help people understand some of these data sets. And I'm aware that we've got a mixed audience out there, so some of you will be very familiar with this type of data, but others who aren't, I'm going to just try and walk you through it. And before I do that, I just want to pay credit to a couple of people. One is Dr. Hugh Williams, who's the data lead for this project, and who I've been working alongside to try and support that, and also to Lightfoot Solutions, who have been compiling the data on behalf of Cardiff and Vale Health Board. So, and what's important about this is we've been quite short of data that crosses boundaries up till now. So I think that's a point worth making, that as GPs, we're quite data rich with our IT systems and in secondary care similarly, but there hasn't been a lot of data that crosses the boundaries and shows us what happens to patient pathways as they move between the two. So in itself, the fact that we've now got this data being collected across Cardiff and Vale, indeed for every cluster, but particularly for clusters such as the Southwest, where Karen and her team work, which can demonstrate the impact on patients of the initiatives they're taking. So just to explain this graph, it's an SPC chart which shows us continuous data over time. And in this case, we are looking at a count of emergency admissions into one of our local district general hospitals, in this case University Hospital Llandoch. And for those who don't work in the locality, just to clarify that this hospital accepts emergency admissions with some exceptions, which would include emergency surgical admissions, patients requiring emergency trauma and orthopaedic intervention, and also some paediatric and cardiovascular emergencies. So primarily this is medical admissions that are unscheduled and emergency, and this is data for Karen's Southwest cluster. And we're lucky to have a 2-year data set here. And the value of that really is that we can look at the baseline of what admissions looked like before any of this project started. And that's really essential if you're trying to prove that what you're doing is actually having an impact in a good way on patients and your team. So if you just look at the chart, you can see the upper and lower control limits, which are depicted in salmon-coloured zigzag lines, and they just show us the range of variability in this system. So you can see the count of admissions each week varies over time, and we call that normal variation. We expect that to happen in any process. And what's depicted by the green line in the centre is the average. So you've got a count of admissions going from one side at about 45, and at the end on the right, it's gone down to just over 30 patients per week being admitted as emergencies. So what's causing the change? Well, you can see from the ovoids in there, there's a red ovoid and there's also a blue ovoid, and these are indicating the time at which some of the interventions that Karen has described were initiated. Now remember, when they started, they would need to mature, so they started in a small way and matured over that time period. So first of all, we had the MDT meetings, which came in at the beginning of 2009, and then we have the Discharge Liaison Hub, which came in later that same year, and that's depicted within the blue ovoid. Now, between the red lines, you can see the variability in the data. And as I said, we've had some normal variation. I want to move immediately to the most obvious change in this data, and that is within the blue circle. So if you look within that, you see what we call special cause variation, and that is a reduction in the count of admissions over that time period. You'll note that it was the summer of 2019. It coincides with the Discharge Liaison Hub opening and becoming mature. And you'll also note that thereafter, when you go to the right of that, that some of those gains in reduction of admissions were then lost. But that also fits with the seasonal element we see in this chart, which is that the count of admissions over time inevitably has some seasonal variation, and we expect hospital emergency admissions to increase during the winter months in this country because of the increase in respiratory illnesses. And again, the benefit of having such a long data set is you can compare the fact that even though there was some loss of the improvement in the winter of 2019, if you compare that winter with the previous winter, 2018, which you see on the left-hand side of the chart, you can see that even though they're both seasonally affected by the winter months, there is an improvement in this year when the project was running over and above the previous year before the project was started. I suppose I should also mention the fact that on the far right of the graph, we've got green data dots again and a dramatic reduction again in the admission count. And this, unfortunately, was not within our sphere of influence. This was caused by the COVID pandemic that we're all familiar with, patients being afraid or avoiding hospital admission for various different reasons. This data set is a few months old, and we're now starting to see an increase in admissions. But I think it does demonstrate very powerfully on this slide that there has been an improvement and a reduction in admissions, possibly through a combination of the interventions that Karen's described. This graph alone doesn't prove which of those interventions was the strongest, and it's important to say that both the MDT meetings and Discharge Hub have now continued in parallel and are mature and continue to be used. But the combination of that in reducing admissions, I think, is compelling. I think the other thing to say, although we haven't got the data to show you, it would take too long, is we have the same data set across every cluster in Cardiff and Vale. And I can tell you that even though all admission counts have been affected by COVID across every cluster, what we're seeing in the southwest cluster of Cardiff is that the admissions have reduced over and above those other clusters, even in spite of COVID and in spite of some of the admission count now increasing. So we see a sustained improvement. Now, this is just one of very many data sets that this team are looking at, but that just gives you an example of how some quantitative data across the boundaries of primary and secondary care can be really useful to evaluate the impact on patients. Next slide, please. Now, the team at Southwest Cluster also wanted to look at the 30-day readmission rate, and this was possibly as a way of measuring the impact of the Discharge Hub and increased support that patients are getting, which improves their resilience and seems to protect them in some way against further readmissions. So in these two charts, we're looking at data again over time, but we're using a technique called regression analysis to look at our topic of interest. And in this case, we've got the 30-day readmission rate on the left in the same cluster over 6 months, and the 3-day readmission rate on the right over the same cluster and the same time period. And these data sets were taken when the project was matured and has continued since. So what's important here is in primary care and probably in secondary care, we count readmissions soon after discharge as a failed discharge because something has gone wrong that meant the patient is not resilient or not well enough to remain at home, and that is a multifactorial problem. So to reduce readmissions would be regarded as an improvement, and that's what these analyses were meant to show. Now, all you can show from this is that there is a relationship over time between the readmission rate. And what we can see from this is that a linear relationship over time, which is negative. And by that, I mean that over time, the admissions are reducing both in the short period of 3 days and the 30 days. And I think that would be regarded as a good thing. Now, we use this, the R-squared number to tell us how strong that relationship is. The R-squared number can only go between 0 and 1, and you'll see on both of these slides it hovers around 0.38 on the 30-day one and 0.30 on the 3-day one. Now, the best this fit could be would be 1, so this doesn't show the best fit, but there certainly is some impact there. I have to say that these slides do not show causality. They're showing a relationship between time and readmission rate, and we would need other data which we're collecting to prove what is causing this. But it seems reasonable to think that these are in support of the interventions that the cluster have put in, given they coincide with the time and that we've got other data. We have a whole family of measures of quantitative data, and Karen will tell you a little bit now about the other data that they're planning on collecting next. So thank you, Karen, and back to you.
Thank you, Sue. Yeah, can we have the next slide, please? So where are we going next? There is a deadline for this project in terms of evaluation. Our funding lasts until the end of March 2021. So we are under obviously some pressure to, try to demonstrate the impact of what we're doing as much as possible during that time. And yeah, thank you, Sue, for taking us through some of the quantitative data that we've got so far. But also, as I said already, this is very much about well-being. It's about supporting people and supporting their well-being. And so that's a really important measure for us. And we're really grateful to Sue and the team for helping support us around some of the qualitative data that we're now working on, and this involves both staff and patient feedback, and so that's very much work in progress. In fact, we've got a meeting coming up this afternoon just to look at developing that particular area and really getting some robust evaluation in place, because that's to us that is a really important outcome that we need to look at with this project. So I think we're going to move on to some questions now, but just before that, I did just want to mention our whole team in Cardiff Southwest Cluster. This is very much about teamwork, and we've got a fantastic project team that comprises a number of GPs, practice managers, our community development lead Hazel, our project support officer Andrea, and it's just been such a joy to be working as part of a wonderful team in this project. So I'll hand back to Sue now, if that's all right.
So thanks, Karen, and I have to say that I would second that sense of well-being and team spirit that is quite evident when I meet you and other members of the Southwest Cluster. It really is very obvious that it's great teamwork that you're doing. So we have a lot of questions, so and I would say to the audience, although it's nearly time for the session to end, we do have the option to extend and to answer some of these questions. So please stick with us, because we've only really heard a little of what Karen's expertise is within this project. So there's a couple of questions come through for you, Karen. The first one is, how do we optimize the role of social prescribing within an MDT in primary care? And allied to that, and given that there are variations in pathways within different clusters, how can we deal with that and make sure that we're all doing the same thing?
Right, yes, really good questions, thank you. So how do we optimize social prescribers within the MDT? I think they need to be equal partners within that MDT. And interestingly, I was speaking at the National Social Prescribing Link Worker Conference last week, and this was a key question that came up there as well, but also a very common theme about how we really need to work in partnership. It needs to, and all of our partners within that MDT need to very much be equal partners. There are some challenges around that, and particularly around data sharing and information sharing, and that has been quite a challenge with this project. I will say it's taken a huge amount of work and time liaising with the various experts within that to make sure that we are obviously protecting our patients in terms of data sharing and making sure that we are sharing information in a safe way, but with the proper measures in place. That is possible, and then we need to be working with our partner organizations. It's all about relationships, as I said with the MDT. Fortunately we've got really strong relationships, and we have had for some time with our third sector partners, but it is really important. So I think in terms of social prescribers, just forming those connections and links with not only with GP practices, but with all of the members of the MDT. And then I think you mentioned about other clusters and about different systems and different clusters, and how do we make sure this is a real challenge. I'm quite passionate about social prescribing needs to be locally driven and very much tailored to the needs of that community. So I feel there isn't a one size fits all model that can just be sort of set up in different clusters. It needs to be local. It needs to be embedding what's already there in a community. The last thing you want to do is bring in a social prescribing service that effectively pushes out the fantastic work that's already going on within that community. So it is important to work with the community organisations that are there already. All of our communities, the needs are so different. So it is about tailoring things to the particular community and the needs of that community. But then again, obviously you want something so that there is equity of access to support across all clusters. So I think it's a challenge. I'm sorry, I don't have a sort of definite answer to it, but I very much believe it. I suppose there needs to be a robust sort of evaluation, which hopefully we're working on now, so you can make sure that you're looking at the outcomes and the impact of what you're doing. But I think forming those strong relationships and working with your local community is key.
Thank you, Karen. And allied to that, there's a question here about evaluation, really, and I'm not sure who posed the question. It's anonymous, but it says, sorry if I missed this, but do you collect PROMs in primary care, and are you able to overlay the data with this? Now, I think we both know the answer to that, but I'll let you carry on.
Yes. Okay. So do we collect them? I mean, not routinely, but should we? Yes, we definitely should. And that's part of the work that we're doing with Sue and her team now, is to use PROMs. It's absolutely vital that we do that, that we robust patient-related patient feedback to really see the impact of what we're doing. So so that Sue, did you want to say anything more about that?
No, I think this has come up in other sessions earlier in the week, but that the NHS is very rich in process data and counting what we do and how efficient we are and quick we are at doing it. But when certainly in primary care at the moment, we are not as good at showing outcomes. And I would say that you're going to be a pioneer in that in primary care, certainly in this area, in starting to use reported outcome measures, not as standardized sets, but we've organised with CEDA some structured interview questions, and also some of your wellbeing coordinators already using the Edinburgh Wellbeing score, aren't they, Karen? Do you want to just say a little bit about that?
Yeah, so it is difficult. It's difficult to evaluate this sort of work, and again, in the sort of social prescribing world, obviously, as you may know, there's a lot of debate around how do you measure social prescribing, and it doesn't necessarily fit that well with any of the established scores that are there. But we've sort of picked, in some previous studies that we've done, sort of smaller scale studies, we did pick the Warwick Edinburgh Wellbeing scores as kind of the best fit that we've got at the moment. And so our Wellbeing coordinators have been doing some work around collecting scoring, so using that scoring system, and we've got again a small amount of data. It has been quite challenging for them to collect data. When you're actually sort of doing an intervention, doesn't always sort of feel that's right to then be looking at doing scoring systems, but they have got some early data, and again it has shown almost universally a positive impact on wellbeing using that scoring system. But obviously through using proms and through the work with CEDA, we're looking to help the wellbeing connectors to actually to gather that data, because we do acknowledge it's not an easy thing to do, and people do need support in being able to do that.
Okay, we could be here all afternoon with these questions, Karen, but I think probably 2 or 3 more, because I think the audience will be really interested in what you have to say. Somebody has asked if the community groups have sustained themselves after the initial stimulation of gap analysis, as they did in Froome.
Yeah, so far so good, I would say. Yeah, I mean, it is another thing that I found sort of inspiring and humbling about working with community groups is the lack of certainty over funding, and how they go very much from 1 month to the next, not quite knowing where the next pot of funding is going to come from. Always they're absolute experts in applying for funding, which has been very interesting to work with them around that. But so far, yeah, the groups, the gaps that have been identified and the groups that have been set up, they have been modified, obviously, during COVID, but we haven't really seen anything stop. Even during COVID, things have just carried on, but in a different way. And obviously, we hope to see that continue.
Okay. And Katie would like to know if there's involvement of the arts in any way.
Oh, very much so. Yes, and really keen to see more of that involved with social prescribing. I mean, this is one of the beauties of social prescribing. It's so broad: arts, music, nature, so much is involved. And we're again fortunate within the cluster that we do have some key groups that are involved in the arts. We have a really fantastic arts centre within our cluster area who are, do a lot around supporting people with dementia, with mental health problems. So yeah, we're linking in very much with those things as well.
Okay, thank you. And I think perhaps we'll make this the final question so people can go off and have their lunch, and including yourself, Karen, before your next meeting. So finally, what is your exit strategy as things stand after the transformation funding stream has ended?
That's a very good question. Yes, and that's something we are working on, obviously, very hard, because we collectively we can't see this go, and I can't even. I won't even entertain that question, basically, but I'm also very aware that we need funding to support it. I think we've got will and enthusiasm, which is great, and we are exploring, obviously, funding streams and putting together what we might need in terms of bids to enable that to happen. We haven't got any sort of guarantees yet in terms of ongoing funding, so I'm having to sort of keep my options open and look into various different options that there are. But I am absolutely convinced that this project will not end next March. I think the people that are involved in it see the value of it, and we will find a way through.
Lovely. I think that really demonstrates very well your answer to that question. Such dedication and passion for what you're doing, great leadership of this project. And I just love that quote that you just won't entertain it ending. And I think on that point, I would like to say thank you very much to Dr. Karen Pardee for joining us this afternoon in this case study. Thank you for your attendance at the session. Thank you to our backroom staff, Alistair and Sarah, who've navigated us through this session. Please, we'll try and answer your questions that haven't been answered. We've got through quite a few of them. And thank you. Goodbye.